when you eat food, you can't say only go to the healthy cells. Food feeds all the cells in your body, whether they're a cancer cell or they're a healthy cell. We need to prioritise nourishing the healthy cells as best we possibly can and let the cancer treatment target the cancer cells.
Hello and welcome to GPs Talk Cancer, brought to you by Gateway C. I'm Dr. Rebecca Leon and I'm joined by Dr. Sarah Taylor. We're both practicing GPs and GP leads for Gateway C, and in this podcast we share our clinical experiences, reflections and practical insights into support earlier and more confident cancer diagnosis in primary care. Before we begin, a quick reminder. Although anyone may find this podcast interesting, it is designed for primary care health professionals. All patient cases are based on real clinical experiences, but are fully anonymised with no identifiable information. Gateway C is a free early cancer diagnosis resource funded by the NHS England, Scotland and Wales and is based at the Christie NHS Foundation Trust. So we're going to be sitting down today and chatting with cancer dietitian Jo Cunningham, and her full title is Cancer and Gut Specialist Dietitian at Greenlight Nutrition. So Jo, thank you for joining us.
Thank you for having me.
And welcome to the studio.
And to Manchester. Have you been to Manchester before?
I have, yes, only on work, but it's nice to come again.
So we're going to be talking about a couple of cases, but I think the working title that we wanted to bring to this podcast almost is What to Eat When You've Got Cancer.
So that obviously varies by patient, by cancer, by lots of different comorbidities, presumably too. So we tried to highlight this in the cases that we're discussing. So Jo, do you want to just talk to us about the first patient, who I think is quite a common sort of scenario that you see?
Yes, so we're talking about a breast cancer patient, someone whose weight is stable, who they're eating well, but they are consumed by fear about food. And it's probably one of the most common types of patients that I see in my clinic, actually, where people are just utterly overwhelmed by all the noise in the food and cancer space. They don't know what supplements to have. They don't know what to avoid. They don't know what to eat. They're looking for things that can cure. They're looking to do things alongside treatments or instead of treatments, which is obviously even more worrying. And so a lot of what I do in that space is reassurance and building confidence again.
So when would you tend to see people? Do you see them when they're first diagnosed, during treatment or after treatment, or all of the above?
It can be at any time. So a lot of the patients that come to me in my own clinic might have been just diagnosed, or they might have already had surgery if we're talking about breast cancer, and they might be preparing for chemotherapy. Some people will come to me whilst they're in chemotherapy and they're struggling with side effects. And then I've got a whole other subset of patients who'll come to me once they finish treatment and they're looking for like, what next, what now? I want to prevent a recurrence. So anytime throughout any of the journey, I think.
Do you feel that the patient themselves are looking to gain some control? This new diagnosis, or as you said, they might have gone through treatment, they might be through the other side, that either themselves or family around them are just thinking, well, if I can help and control what I'm eating, then I can gain some control back in my life.
100%. So I think a lot of the time they're in this environment where they're just nothing is in their control. And the only thing that they control is what goes into their body. And a lot of the time there's a lot of shame and blame. So they're like, what have I done wrong? What have I been eating wrong? What should I stop eating to stop this happening even more? And so a lot of the time it's like, just let's go back to basics. Let's remember what's safe. Let's remember moderation, or some of the really sensible basics get completely lost. And I'm seeing more and more sort of like more eating disorder kind of behaviours, especially in the breast cancer space, where they're able to find evidence, loosely using the word evidence, of this is unhelpful, this is unhelpful, this is unhelpful. And I did actually have one lady in one of the oncology treatment centres who only felt safe eating broccoli and cauliflower because she couldn't find anything about broccoli and cauliflower that was bad.
So it's a combination of all of these things are going to make you worse, with a few of these things are going to cure you, and trying to find the truth in the middle.
Exactly. And then when you throw into the mix the gut-brain connection, which can then trigger symptoms like IBS,
of course,
they then become even more fearful and confused about food because things start reacting with them and causing other new symptoms that they didn't even have before. And
then makes them worry that the cancer's come back.
Exactly. So it can be really, really challenging. And a lot of the times I will only need to see that type of patient probably once, put them on a good path, and then they're okay.
Okay, so tell us what you would, because I think that obviously in slightly less detail, some of that detail we could give them to get them on a good path.
Absolutely. And I think because one of the things I do hear time and time again, less so from GPs, but more so from oncologists and surgeons, where they're giving dietary advice that is incorrect. So I haven't heard it from GPs, thankfully.
Good.
But I have got ladies that are coming to me saying their surgeons told them not to have dairy, not to have soy, not to have sugar, that they have to cut out this, and it's they are trusting what they're hearing because they're, qualified healthcare professionals.
Yeah.
So what we can say to the patient safely is you don't need to fear sugar, you don't need to fear soy, you don't need to exclude dairy. Gluten's not the bad guy. And a lot of the time, myth busting is a big, I would say sort of like 50% of the session, maybe even more than that, is myth busting, going through sort of which specific foods, which specific diets. There's lots of different types of diets and dietary patterns that are recommended that aren't evidence-based. So a lot of the myth busting is what I do in the first half of the session. Did you want me to go through any of the common myths?
I would definitely. I'm always fascinated by a myth.
Yes, please.
Sugar feeding cancer
Wow.
is the most commonly asked question. Does sugar feed cancer?
Okay.
Is usually the first thing that I'm asked. And if I'm not asked it, within the first sort of 10 minutes of conversation, someone will say to me, well, I'm already avoiding all the sugar. And I then have to unpick, how much sugar are you avoiding? Is it just all the added sugars in your diet, or is it all sources of sugar, which is all our carbohydrates, fruits and vegetables and everything else? And sometimes it's the extreme. Sometimes it's just cutting out the obviously sugary foods, which a lot of us could benefit from reducing, but which we don't need to cut out. They're not going to cause or feed cancer growth.
Because I was going to say that social media will be playing a huge part in all of this, and also TV, and there's programs we've seen on apple cider vinegar, where have you heard of that?
No.
I haven't watched
Good or bad?
Interesting.
No, I mean, is apple cider vinegar good or bad?
I said I've not watched it. The concept. Do you know about it?
I haven't watched it, but I know I would be triggered if I watched it.
I think the premise is it was similar. That
my understanding is it was someone who claimed that she cured herself through diet, but ultimately it was complete and utter it was not true.
But so I think she turned down regular treatments just to cure it herself, and so I think it's a true story.
Okay.
I think we should go home and watch it. Anyway, so social media is going to be a big part of this.
Yeah.
Tell us some more myths.
Yeah. Well, just going back to that, what I would say when someone asks about sugar, because I think that it's really easy to say, no, it's okay, it doesn't feed cancer. But because there is so much noise in the sugar space, I would always say when you eat food, you can't say only go to the healthy cells. Food feeds all the cells in your body, whether they're a cancer cell or they're a healthy cell. We need to prioritise nourishing the healthy cells as best we possibly can and let the cancer treatment target the cancer cells.
That's a really nice explanation.
That's the way I tend to describe it. And I'm like, yes, you can have a cake, a sweet or a biscuit, guilt-free. It's not going to directly feed cancer or make it worse. But let's focus on making sure that we're nourishing those healthy cells with foods that will contain sugar, but also food doesn't just contain one thing. Food contains fibre, it contains vitamins, it contains minerals, it contains protein. We need to make sure we've got a bit of everything to support those healthy cells. So that's how I would be talking about sugar with patients.
That's a nice, I like that explanation.
Healthy versus the cancer cells. It all needs nourishing.
Yeah.
Do you find some of the patients that come to see you find a meal plan helpful? So actually to give recipes or things that they can get involved with cooking and having a bit of a plan?
It's often what they think they want,
okay,
if I'm honest with you. But a lot of dietitians will probably agree with me that meal plans are incredibly time inefficient for us to create because we have to take in personal tastes and preferences and budget. So it can take a lot of time to put a really good meal plan together. And then you've got like what happens on the day, you're feeling unwell, you don't fancy something, it just goes straight out the window and it's just not followed at all.
Is it another thing then to fail or to feel bad about?
Yeah, potentially. So
I'm supposed to be having avocado on toast, on brown toast today, but actually,
exactly.
I want beans on toast instead.
Instead, we talk about optimizing the days when you're feeling good and
Yes.
thinking about the variety and going for the variety. So if I'm talking loosely about meal planning, I will suggest maybe that they pick their protein first, match a carb to it, preferably a whole grain carb, rotate that across the week so that it's not the same every day, and then build all of the rest of the veggies and other plants onto the plate as well. So I do loose meal planning, but I will probably prioritise the protein source first and load up on the fibre.
And your general gist of advice would be the same sort of advice you're giving to patients with cardiovascular disease and maybe patients who are all sorts of other diabetic patients, about just general healthy eating?
Yeah, so when we're looking at the global evidence, there's lots of different dietary patterns that are beneficial to follow. We've got calorie controlled diets, we've got the hypertension diets, but ultimately Mediterranean dietary principles, time and time again, are evidence for a huge range of different chronic diseases. So yes, it's cardiovascular protective, but in terms of cancer risk, in terms of cancer prevention, in terms of survival and longevity, Mediterranean principles are where it's at. And we can apply those principles across all of the cuisine types, but I can't do that with my patients until I've done all the myth busting first. Because if I start telling them to go and have some tofu or some soy, they're going to say, but that's not safe for me with breast cancer and it's a hormone-driven cancer, and they won't believe me. So I have to make sure that they feel really confident with that myth-busting section first.
So you said myth. So you've talked about a couple. You said sugar-feeding cancer, soy.
Soy's a big one, and actually it's one. I was involved in a literature review last year, specifically for breast cancer survivorship and looking at diet. And in the last 5 years, there's been a huge amount of research looking into soy and breast cancer specifically. Soy used to be feared in the breast cancer space because they contain these chemicals called phytoestrogens. So they've got the word estrogen in the name. So the fear used to be estrogen in the name is going to feed hormone-driven cancer, make it worse. What we know now is the exact opposite of that. So these phytoestrogens, type of isoflavone, a plant-based chemical, they look a little bit similar to the hormone estrogen in a microscope, but they bind to estrogen receptors to help lower circulating estrogen. So they actually can be really protective and beneficial potentially when we're thinking about risk of recurrence and survival outcomes. The World Cancer Research Fund doesn't recommend that we have to have soy, but it says if you already are having it, it's safe to continue. And if you don't have it already, maybe you want to maybe think about including some. And in breast cancer specifically, because a lot of them will go into medically or surgically induced menopause, soy has been shown that it can help to reduce vasomotor symptoms like hot flushes as well. So it can be an incredibly powerful one.
I don't suffer from hot flushes. You don't need to say that. But edamame is supposed to be very good for perimenopause as well.
Okay.
Yeah. Also, I mean, a lot of the studies they did in soy were looking at soy milk. They did use soy milk in the studies, but we've got tofu, tempeh, edamame beans. It doesn't really matter. It's beneficial in the body, but we don't want soy supplements.
Okay. Other myths. Any other big
dairy
ones?
In the breast cancer space. Dairy is another one.
For what reason?
Messing with hormones, primarily. There's a fear that it messes with hormones.
Inflammation as well, maybe.
Inflammation, yeah. And a lot of people feel like they're dairy intolerant. Not everybody is. A lot of the time, I mean, when I'm hosting webinars and things like that with breast cancer charities, dairy is one of the commonly asked questions. And my answer is, as a dietitian, I'm not here to tell you have to have dairy or don't have dairy. Whatever you decide, I want to make sure your diet is complete. So if you're not having dairy, we want to make sure you've got enough protein, but also calcium, also iodine. People don't ever think about iodine when they're taking dairy out of their diet. And if we're having a plant-based milk, a lot of the time, some of them don't have those nutrients added back to them. But dairy in the UK, tightly regulated. We don't add hormones to it. Any hormones naturally occurring in dairy aren't shown to affect our hormone levels. So if we want to have dairy, we absolutely can do. And when we're thinking about colorectal cancer and breast cancer, there's some evidence that it may actually be protective. So I'm for it if you like it, probably fermented dairy for the gut health benefits.
And what about gluten? Because that's the other thing that...
So with my gut dietitian hat on, gluten gets a lot of bad press.
Yes,
a lot of bad press.
It gets a lot of bad press.
Especially with people with irritable bowel syndrome, which a lot of cancer patients develop, or they might have undiagnosed IBS afterwards, just through gut-brain connection stuff. Gluten is the protein that's found within wheat. There's also within wheat a type of sugar, and that sugar is very highly fermentable when it gets into the large intestine. Our microbes love it. They feed on it and they produce beneficial gases, which are actually really anti-inflammatory in the gut. But a lot of the time, that fermentation causes bloating and wind. And so people associate the gluten as being bad, but actually it's the amount of that fermentable sugar that they're having. And actually, if we just space out our grains, space out our whole grains, rotate when we're thinking about meal planning, if we sort of like lose the sandwich every single day or the toast every single day and rotate what we're having, we reduce that fermentation and manage our symptoms.
And so if Rebecca and I were trying to give the principles of the Mediterranean diet to one of our patients in a 10, 15-minute consultation, what would the key things that you'd try and get across be?
Probably look at fat sources first. So when we're thinking about Mediterranean diet, the principles of it can be applied to any type of cuisine. And sometimes it's like swapping the fat that we might be cooking with. So maybe instead of using like ghee or coconut oil, we might want to use olive oil or even rapeseed oil. Seed oils are fine. They're actually beneficial to our body. So that would be one thing I'd want to look at. Swapping white carbs for whole grains. So including more whole grains, using some whole wheat flour or 50-50 mix, maybe getting some, you don't have to go full brown every single time, but changing the different types of rice that you're having. You can also add nuts and seeds and things like tinned beans and lentils. There's loads of things that you can get that are actually quite cheap that you can add to meals without changing the meal too much. Adding things in is usually the most helpful. I'm always about inclusion rather than exclusion.
And the thing about cooking on a budget as well. So you're talking about what changes can we make. We can't be telling everybody to be having lots of very expensive fishes and lean meats and whole meal might be more whole grain. So just eating well on a budget. Can you give us some advice on that?
Yes, and I was doing a little bit of research on the way up on the train actually, just to see, because I know from speaking to some of my colleagues who work in the NHS, a lot of their patients might be surviving on meal deals and takeaways a lot of the time. And there's obviously an access issue. Some people don't have access to large supermarkets. They might just be relying on local supermarkets. But ultimately, a meal deal can vary between sort of like £3 to £6, depending on where you go. For £6, you can buy a packet of spaghetti, you can buy some mince, you can buy some tinned tomatoes, and you can buy some carrots and beans, and you could make 5 or 6 portions of bolognese to last you. You could also, for the same amount of money, you could buy a whole loaf of wholemeal bread, a block of cheese, some lettuce, you could probably buy some hummus as well. And you could probably make multiple sandwiches out of that rather than, and some apples included in the mix, some extra fibre, maybe even some nuts, that you can actually make the money go further. It's just that it's not as simple, it's just not as accessible. So usually it's if I'm coaching a client, speaking with them, it's about finding a few things that we can focus on first, and it's the baby steps. If we try to change everything at once, it is too overwhelming. So usually it's about what's this one thing that we can add in first.
Yeah, absolutely.
And when I'm speaking with my clients and I'm doing their food history, sometimes it's like the little things like nuts and seeds where they're missing from people's diets. Yeah. A lot of sort of like the more Middle Eastern or Asian cultures will have lots of legumes in their diets, but they don't have as much seeds or leafy greens perhaps. So usually there are just a few things that we'd start with, and then we would build on it from there.
So I was always told, cook like your ancestors. So almost cook from scratch.
Yeah.
And that's a small change I have made in my house. Well, Matt does most of the cooking. But it was something, just cook from scratch. And it's not difficult. And it
does take organisation, doesn't it? Because I love to cook, but I always say that actually it's deciding what to cook and it's making sure you've got the ingredients. And
you need a good pantry.
Yeah, but then that is more difficult if you're on a budget, isn't it, to stock things up?
But then things like tins and frozen can be something that you can actually have. Tin lentils and the butter beans and the things like that. You can actually get them fairly cheaply. Yeah. Tin tomatoes, and then you can get the frozen everything.
Definitely.
Yes.
And I'm a big fan of, batch cooking.
Yes, me too.
It can make it really more affordable.
Leftovers for lunch.
Definitely leftovers for lunch. And if you're thinking about gut health and supporting the gut microbiome, which, again, huge amounts of emerging evidence in the cancer space about supporting the gut microbiome before you start treatment, if possible, but also throughout and after treatment. So the more that you can do in terms of adding in plants, the better.
I say to my patients, Sarah, that starting cancer treatment, whether it's going down the surgical route, down the chemotherapy route, is preparing for a marathon. So it's getting yourself almost marathon ready. And I think from a gut health point of view, from if you need to put a little bit of weight on, if you need to get a little bit more active, it's about that advice of making a few changes to start to feel better, ready for the attack that was going to happen.
So if I see somebody who comes in for a post breast cancer treatment and is obviously anxious about diet, your advice would be initially try and find out what they're avoiding and why, and do some myth busting, and then just give some simple advice on things to add, things to change, maybe putting 2 tins of beans into your chili rather than different beans into your chili. That sort of thing. Adding some. I've got a bread maker and I make bread, and I've started chucking lots of seeds into that. All sorts of different seeds because it's very easy to do. But that's a bit more. But just generally, just adding just a few small changes and a bit of myth busting is probably as much as you and I are going to be able to do in our consultation.
Absolutely.
And the prehab.
The British Dietetic Association's got some free resources that you could always signpost patients to as well.
Perfect.
So they've the oncology subgroup of the British Dietetic Association have got a myth busting fact sheet.
That'd be really good.
That is free to download, which I can always give you for the show notes.
Yes, we'll have that in our show notes.
I want to talk to you about supplements.
So does everybody.
Yeah, I mean, we're all taking loads, and is that part of the myth busting as well? As in, supplements will either cure or not cure cancer, and also just talking about when supplements are important.
Yeah, I get asked about supplements as well. Yeah, we probably spend at least 20 minutes of a session talking about supplements. Some people have maybe seen alternative practitioners and maybe have 2 or 3 A4 sheets of supplements that they have been prescribed. And a lot of the time, those supplements will interfere with each other or with cancer treatment medications. So one of the things that I will always say to any of my cancer patients is any supplements you're taking need to be cleared by an oncology pharmacist, because some of them may mean that the chemotherapy is staying in the body too long. Toxicity is going to happen, and some of them will mean that the drugs are going to pass out of the body too quickly, which means it may not be as effective. So we want to make sure that supplements you're having are safe. In terms of key supplements, vitamin D is one that I would make sure is
everybody should be on vitamin D.
Everyone should be on vitamin D, and I would encourage, where it's possible, everyone should find out what their level is in order to tailor their dose to what they need. So a lot of the time, cancer patients will, when I get their levels tested, they are deficient or almost deficient, or sometimes they'll say on their NHS level is adequate, but they don't get told to supplement on the adequate when actually they probably do need it because they're about to fall into the sort of deficient range. So optimising their vitamin D, because it's so supportive of their immune function, is one that I would always do. Because 9 out of 10 people experience cancer-related fatigue, I will often, and obviously if they're coming to me after treatment, that's something that they're looking to improve upon as well. And it is multifactorial, but we want to obviously make sure that there's no deficiencies like any iron, folate or anything like that they're low of.
And B12.
And then other supplements I get asked about a lot. Turmeric is one that gets asked about a lot.
We talked about that, didn't we?
And I mean, it is a very anti-inflammatory property. There's curcumin is well known to help to reduce inflammation, but again, it can interfere with certain medications, certain types of cancer treatments. So whilst you may see it being used in some spaces, it's not going to be applicable for everybody. Once someone's finished cancer treatment, if it's safe for them to, I don't have a problem with them doing it, but I would always let them know when the evidence is there or not. So But it's a very complicated space, and there is a great resource that I sometimes signpost people to, which is it's an American cancer site that has got a great resource called About Herbs, and it shows you all the herb-drug interactions. It is a brilliant resource, and it's got an app that patients can download as well.
So I think we're going to keep it simple for our patients and just give a few simple principles and check levels to make sure we're not missing anything that needs.
And if they're not eating well and they're on cancer treatment, I would normally recommend a multivitamin that contains 100% of the recommended daily amount and not more than. So some vitamins and minerals, you'll see on the back of the packet, it will say 2,000% of your RDA. If you're on, I mean, some have B12 like 20,000% of your RDA.
Yes.
And actually, what some of these high dose antioxidants, vitamins A, C, E, they can be a bit too protective of the cells for someone who's on cancer treatment. We don't know enough about it yet. So while someone's on active cancer treatment, 100% and no more than. And some of the supermarket brands and high street brands have particular ones that do that.
You can see that when you get B12 levels back, if you've checked somebody's blood level. A lot of my patients seem to have way above the upper limit.
It can go high in oncology as well.
Yeah, so that's useful to know.
Can we talk about case 2? Because I think this comes up with just a few other things. Because case 1 really talked about all the things for general practice, about myth busting, eating well on a budget, the Mediterranean diet, and supplements. So I want to talk about case 2. Jo, can you tell us a bit about that?
So case 2 is a man with pancreatic cancer. They've had surgery. They're eating okay, and they're using nutritional supplement drinks, but they've got ongoing diarrhea, pale stools, bloating, weight loss. So really, when someone presents to me like this, I'm just thinking malabsorption, but I'm also, there's multiple different types of malabsorption. So when someone's had gastrointestinal surgery, they might not have their pancreas, or they might only have part of their pancreas. So they're going to need digestive enzymes to digest and absorb their nutrition. Most of the time, not all the time, but most of the time, those pancreatic enzymes are prescribed incorrectly, unfortunately. They're prescribed 2 tablets 3 times a day, and there's no guidance on how to take them properly. So part of a dietitian's job is to provide the education and support of the correct dosage, which will often be writing back to the GP to say this is how much the patient actually needs, which is probably 5 times the amount that they might have been originally prescribed. And once we optimise those digestive enzymes to make sure that the food is actually going to be broken down and absorbed, a lot of those digestive symptoms do improve. But they may have other things going on still that are causing malabsorption. So they may have what's called bile acid malabsorption. They may also have a small intestinal bacterial overgrowth. Those 3 conditions present very similarly. So I would always want to be making sure that I'm screening and assessing for all of those things, anyone who's had any type of gastrointestinal surgery, or if they've had radiotherapy down there as well, because that can be really tricky to manage for years after treatment's finished.
And this is where general practice is getting more involved, because actually post-surgery, the consequences of anti-cancer treatment, if they're now presenting with possible malabsorption, it's what we do with this.
Yeah.
I personally, Sarah, would you speak to the oncology CNS and talk to them about what to do next? I would hope that
a lot of these patients, would have spoken to a dietitian at some point in their journey. Wouldn't you?
So.
Really would, because I think, whereas the first patient, I think obviously is a benefit, but we can do a bit. The second patient, I think it's just so far out of our area of expertise that I think it is very difficult for us to do. But I suppose what's important in this patient is to recognise that this is quite a complicated patient, and as you're saying, go back to somebody and say, well, I don't know.
Yeah.
Please help me, because I don't think we're going to sort that patient out.
But it's asking the right questions. So it's asking, because they might be telling you that they've got diarrhea and that they've got bloating and pain, but we might want to find out what's the colour of the poo, and is there any fat in the water? Is there any oil in the water? Is it difficult to flush?
Yeah.
They might not have even thought about that themselves. When I ask them that, sometimes I haven't really looked. I'm like, well, is it feel greasy when you're wiping? And when they think about, I have had people send me pictures of their poo because they're not sure. But that's often those type of malabsorption symptoms actually appear last. So sometimes someone can have like a perfect type of poo but still be malabsorbing, and which is where sometimes I might be pushing back to GPs to say, well, let's check some fat-soluble vitamins. If this is, if this patient's been struggling for a really long time, that will tell us how long they've been malabsorbing potentially.
The fecal elastase we'd do, wouldn't we? For this? Yeah. Okay.
Yeah. I mean, if they've had a total pancreatectomy or distal pancreatectomy, I would want Creon straight away anyway.
Yeah. So when do you think we should be going, this isn't for me to deal with, somebody else should be, this needs more specialist advice? What sort of situations do you see where you're thinking, I wish somebody had asked me earlier? Probably most people.
I mean, anyone with an upper GI cancer, so esophageal, pancreatic cancer, head and neck cancer, just goes without saying, they automatically should be under the care of a dietitian. But really, it's if they're eating but they're not gaining weight, or if they've got ongoing side effects. And I mean, I get bowel cancer patients that have, finished treatment 3 years ago and they're still having diarrhea 15 times a day, and no one's told them that their risk of bile acid malabsorption is around 90% after surgery. Everyone was so focused on the cancer that they didn't focus on the after effects.
They almost don't want to complain. We have this. We've had conversations with urologists on this podcast where they've had a prostatectomy and they've actually struggled to have any sexual intimacy for years after, and they've not wanted to complain because it's, well, I'm better now. Yeah. So I can imagine with the bowel cancer.
Prostate cancer as well, because of the radiation to the area. They don't understand why they've got this diarrhea with malabsorption symptoms, because it was a prostate cancer. It wasn't anything to do with the digestive system.
It's the pelvic radiotherapy.
Exactly. So I think it's, if anyone's really struggling with ongoing persistent symptoms, gut specialist or a cancer specialist dietitian, depending on what the actual struggle is, can be important. If you're thinking that they need nutritional supplements prescribed, in an ideal scenario, a dietitian would assess which one would be right for them. I know that we're obviously tied to the specific manufacturers, and depending on what your trust is, but sometimes they're not right for the patient. So we do, where it's possible, we do try to make sure that we're matching the nutritional needs to the client. So we have some supplements that are 125 mils, and then you've got some that are 200 mils. For someone with really poor intake, 200 mils is a lot for them. And that's only 300 calories a day. But if we can give them the compact versions, they can manage 3 times the amount, and then they've got huge amounts of calories. So signposting them as soon as possible to prevent weight loss or further malabsorption issues would be my recommendation.
Do you still use the MUST score? Yeah.
Yes, that's more in hospital settings. But I would always be asking them about their weight history. And sometimes people have lost a lot of weight, but they will still look like they're in a bigger body, and they can get missed. So just because someone is overweight, it doesn't mean to say that they're not at high risk of malnutrition. And that, I think, is one of the people that can be missed, because we want to make sure if they're in a bigger body and they've got cancer in their body, their protein requirements are probably double to what someone doesn't have cancer in their body. And sometimes we need protein supplements to meet their nutritional needs.
That's interesting.
Yes, isn't it?
So I get questioned, particularly with my frailer patients. So let's use an example of a 90-year-old with metastatic breast cancer with increasing frailty. And I get a call to say from the district nurse team, we'd like to start the patient on oral nutritional supplements. Her eating is okay. She's always eaten like a bird. This is the kind of calls I get. The family would like her to be started on Ensure, as an example.
Yeah.
How do we go about with that? Because we're not able to fully review her oral intake and what she's getting and not getting. And she's at the stage of life where she's probably not going to put seeds on her porridge. Might be wrong. So what do you think about giving a prescription for?
I would always look at food first, because there's a lot of food fortification advice that you can probably give in your clinic room. So, for example, Marvel skimmed milk powder. If you were to add a few tablespoons of that to a pint of milk, you've doubled the protein content of that pint of milk.
Right.
And you've increased the calorie content by a couple of hundred calories. So if they then are using that pint of milk to make their porridge, even if it's a small amount, you've got a boost of protein and calories. And sometimes those little things like that can really add up. And a lot of the advice that is often given is high sugar, high fat. So it's like cream, it's butter, it's sugar. Sometimes a lot of my patients, even the elderly, frail ones, they don't want that. They're like, I don't want to just keep adding fat and sugar to my food. So then it's just thinking a little bit more, okay, well, what about some olives? What about some avocado? Can we mash some avocado with some sardines to make a little paste for you, like a pate, for example? And then it would be probably having a chat with the family about losing the idea of breakfast, lunch and dinner. And often it's the family's pressure to provide the breakfast, the lunch and the dinner. They are the ones who struggle the most with seeing their family member struggling. And actually, if we just maybe set an alarm for every 2 or 3 hours and just present something small, we can probably get a lot more nutrition into somebody. If we wanted to go down the Ensure, the oral nutritional supplement route, checking what flavours they like, reminding them that it tastes better when it's chilled. It tastes quite sickly when it's warm. So if you're prescribing it in the summer, it can be quite unpalatable. You can make some of them into ice creams. You can put some of the juice ones and freeze them into ice cubes. There's quite a lot of information on those manufacturers' websites about how you can use them that are outside of just a drink. So I would probably signpost to there, but put them under a dietitian.
Yeah, I think that for the majority of our patients, we're very strongly encouraged to get dietitian advice before we prescribe oral nutritional supplements. And I would tend to, just because otherwise I think you can end up prescribing something that's of limited value for a very long time.
Exactly. And we can often make our own homemade smoothies that patients enjoy the taste of much more, and we can get a pretty good amount of calories and protein and things in there. So I'm always a big fan of really listening to what the patient wants, because if the patient doesn't want to eat ultimately, if they want to start that process of not eating as much and declining, we do have to respect their wishes. We can't force somebody to eat, even if the family are panicking about it.
One more question. Protein powder.
Yes.
Good or bad or ugly?
Depends. The dietitian's answer is always it depends, because there's so many different types.
Like a politician.
Yeah.
So adding it to a smoothie that you're saying.
Well, if someone has some of those digestive symptoms, bloating, for example, or flatulence, whey protein might make them worse. So there are some protein powders that can increase digestive symptoms. So it's choosing the right type for the person. We've got hemp protein, you've got pea protein. There's different types of protein powders. I'm a big fan of rotating them again, because then you're not overloading the gut on any one thing. But a lot of us are prioritising protein, and then protein is really important. Your requirements can be double with cancer in the body, but most people want to be also prioritising the fibre. And I know you've talked about fibre on the podcast before, but fibre is the thing that people are missing out on the most. There's so much focus on protein at the moment, but fibre is the thing that can reduce the risk of recurrence. Fibre is the thing that can support you in terms of your longevity and your immune system. So I would be less worried about the protein powders unless there's a specific need, because for a 60-kilogram woman, for example, I could eat 1 chicken breast a day, a large normal-sized chicken breast, and that would almost meet pretty much my needs. Whereas it's the fibre that people are missing out on.
So these other diets that are being discussed, the keto diet, carnivore diet, like the caveman's diet,
intermittent fasting.
Yeah. Are these any good?
The keto diet, sometimes I will use if someone's got uncontrolled seizures, like with glioblastoma, for example. There is clinical evidence that it can help manage seizures. Okay. For every other cancer type, there's no robust evidence that we need to follow a ketogenic diet, which is where we're taking out all sugar sources and we're using fat instead for energy. A lot in the breast cancer space, there is a lot of buzz around the keto diet, but we want to just focus on what we know. Plants are the good guys because of the fibre. And if we're going keto, we're taking a lot of those plants out. So I'm always like, until we know anything else, we keep all those plants in.
Okay.
Fasting, another really popular area, especially in the breast cancer space. Again, we don't know enough yet. Early clinical data is exciting, but it's in test tubes and it's in mice. It's not in humans. I usually will say I can't recommend fasting to everyone. There's certain people where it would be actually dangerous for them to fast. I've had people turn up to the chemotherapy units and they've been so fasted that their electrolytes are all off and they can't have their treatment that day. So I would usually just talk about, okay, well, if you're thinking about fasting, maybe just have your dinner a bit earlier and your breakfast a bit later. But we need to make sure you're eating enough when you're eating, ultimately. But there is some exciting research, looking at a starved cancer cell is more vulnerable. So it's like, watch this space, but I'm not going to recommend it to anyone. Whatever you do, your oncologist needs to be on board. Carnivore, I'm definitely not on board with. Some people will feel better going carnivore because they're like taking some of the fibre out and they're reducing the fermentation in the gut. But ultimately, they're going to be increasing inflammation in the long run and doing themselves no favours. So it's a big fat no from me.
Not even a depends.
Not even a depends on that one.
Just a no.
No.
Yeah.
But we do, the vegan diet, we don't have to be vegan. But we do know that the more plants we have, the better.
Yeah.
So the more plant-based proteins and other types of plants we include in the diet, the better. But I'm a big supporter of animal proteins used sparingly in the diet. In the older, just going back to your sort of like the caveman sort of principles, the cavemen died young, but they would have been catching small birds in this country. They would have had pheasant and pigeon and quail and partridge and things like that. We wouldn't have been having cows every single day. Yeah. So it would be about rotating those smaller protein sources, the smaller fish, the oily fish, and then having some plant-based protein in there as well. So I'm a big fan of diversity.
Diversity. Yeah. Great. Okay. So, key points. I'm going to say myth busting.
I'm going to go, I think I'll go for diversity because you've just put that in and it seems like a good one to...
So a mixed bag.
Mixed bag, just, nothing's out, nothing's curative.
Yeah.
Or I might even go for it depends.
And a third clinical point before we go, Jo. If there's one thing that we could take away.
I would just be very wary about where you're getting your information from.
Yeah.
I think on social media, there's only 2% of the information on social media about nutrition is correct.
Wow.
2%.
Then you go down an algorithm.
Yeah.
Yeah. And then once you've started looking at things on social media, it will pull in more things that will support your theory. So be careful where you get your information from. Choose trusted sources. Yeah.
Great. That's really helpful. And I like that American one about herbs. Because we get on everything, every supplement says ask your GP or ask your health professional if you're not sure. We don't know. No. Okay. Final thing. Word of the podcast.
Have we not just done that?
No, we did key clinical points. You got confused.
Oh,
that's why you said diversity.
Oh, I might use diversity again.
Is that going to be your word of the podcast?
Yes, I think so.
You're going diversity?
Yes.
Where are you going to go, Jo?
I was going to go diversity, so what shall I do? I'm going to go simplicity. Take it back to basics because actually we don't need to cut everything out. We need to keep a lot of things in. Go back to basics, keep it simple.
And I'm going to go depends.
Fair enough.
Thank you, Jo, so much for being with us today. I thoroughly enjoyed it.
It was really good. Yeah, really,
and I hope
really
you have and a safe journey back to London.
Thank you very much.
Thank you.
Thank you for listening to GPs Talk Cancer from Gateway C. You can access our CPD accredited modules anytime via our website, and all reference studies and guidelines for this episode are linked in the show notes. Big thank you to Jo and to our producers from Gateway C and Listening Dog Media. If you haven't already, please follow the podcast so new episodes drop straight into your feed. And if you think a colleague would find this episode helpful, we'd really appreciate you sharing it. It helps us reach more primary care health professionals. Thanks for joining us, and we'll be back again soon. Bye-bye for now.